Today I will be discussing atrial fibrillation, and through the rest of this presentation I will refer to it as Afib. Afib is the most common arrhythmia worldwide. It affects 33.5 million individuals. Risk factors for Afib include hypertension, obesity, valvular heart disease, heart failure. These risk factors cause physiological aging and cardiac remodeling of the heart, which results in structural remodeling. This can cause triggers that initiate and maintain the arrhythmia. The graphic on the right is from a patient with obesity. These are changes that can occur: an increased left atrium, pericardial fat, left ventricular enlargement. These are changes that could initiate Afib. A significant amount of patients are asymptomatic. When patients do present with symptoms, they can include palpitations, chest pain, lightheadedness, dyspnea. A complete cardiovascular exam should be performed on a patient with Afib, including a thorough history. A common finding on exam is an irregular rapid pulse. Patients may also present with symptoms of their cause of Afib, such as a patient with heart failure might have peripheral edema, and symptoms such as this might lead you to the patient's cause of Afib. An electrocardiogram is used to diagnose AFib. It's useful when the patient is in AFib during the time of recording. Typically it shows an erratic, disorganized atrial activity between discrete QRS complexes, and these occur in an irregular pattern. The atrial activity may be difficult to detect, or it can be quite obvious. The top rhythm strip shows a coarse AFib with moderate ventricular response. The two characteristic findings of AFib are present: the very rapid atrial fibrillatory waves and the irregularly irregular ventricular response. So the R to R interval between beats is unpredictable. The bottom rhythm strip represents minimal atrial activity, with the only finding suggestive of AFib is the irregularly irregular ventricular response. A transthoracic echocardiogram is useful and should be done with patients being diagnosed with AFib. It evaluates the cardiac structure and function of the heart, as well as assesses the presence of thrombi, which should especially be done before patients who are going to undergo cardioversion due to the increased risk of embolization. Additional tests such as a TSH should be done to rule out hyperthyroidism as a potential cause of AFib, and tests to rule out certain underlying risk factors should also be done, such as screening for diabetes and a BNP to assess heart failure. Now on to treatment. Treatment consists of rate control and rhythm control. Rate control is usually achieved with beta blockers or calcium channel blockers. Rhythm control may be preferred in patients whose symptoms persist despite rate control. Rhythm control can be achieved using cardioversion, antiarrhythmic medications, or catheter ablation. Ablation is commonly used for patients with drug refractory symptomatic AFib. Stroke prevention is a primary goal in management of AFib. The CHAD-2 VAS score is used to assess patients and their risk of stroke. It takes into account risk factors and age, and it gives each risk factor a score of 1 or 2. Congestive heart failure, hypertension, diabetes, vascular disease, age 65 to 75, and the female gender all get 1 point. Age 75 or greater and a history of stroke or TIA gets 2 points. A score of 0, there is no antithrombotic therapy recommended. With a score of 1, either oral anticoagulation or antiplatelet therapy is recommended. With a score of 2 or greater, oral anticoagulation is recommended. Warfarin is the standard therapy for oral anticoagulation. There are other choices such as Pradaxa and Xarelto, all of which have pros and cons that should be discussed and looked at for depending on the patient. Aspirin is the therapy used for antiplatelet therapy. Prevention of complications is aimed at patients receiving the proper treatment for their cardiovascular risk factors. Treatment of these may prevent the progression of the cardiac remodeling, thus preventing the onset or recurrence of AFib. Physical activity and weight loss has been proven to significantly reduce the burden of AFib. It is important for patients to be educated on the symptoms and risk factors of AFib due to the great impact these complications have on morbidity and mortality. Here's a list of my references. I hope you enjoyed this presentation and good luck on the boards.